Greetings again, everybody. We're going to talk here about the substance-related and addictive disorders, as the DSM-5 calls it, also known more colloquially as the substance use disorders. Alright, so there are two new withdrawal syndromes the DSM-5 recognizes, the first of which is cannabis withdrawal syndrome, the other is caffeine withdrawal syndrome, which we've probably all experienced at one point or another. The caffeine one, not the cannabis one. Maybe you've had that one too, I don't know. Anyhow, the cannabis withdrawal syndrome is, you would think, based on all the stuff that you hear in popular culture, marijuana is not addictive, and yes, it is true that marijuana is not addictive to the same degree as other illicit drugs such as cocaine or methamphetamine or heroin. However, there are addictive properties to it, as there are with pretty much anything that you take into your body, such as caffeine or alcohol. So yes, there is a cannabis withdrawal syndrome, and we now recognize this in the DSM-5. So the first criterion for cannabis withdrawal syndrome is that the patient has stopped using the marijuana after a period of heavy and prolonged use. So that's really up in the air how long. It depends on how much they used it and really just various factors based on the patient. But the DSM says usually daily or almost daily over a period of at least a few months. So a pretty significant history of cannabis use. Next, they have to have 3 or more of the following signs or symptoms developing within approximately 1 week after cessation. And these are irritability, anger, or aggression, nervousness or anxiety, sleep difficulty, and that can be difficulty initiating sleep, difficulty maintaining sleep. A lot of times these patients will have strange dreams, nightmares. Decreased appetite or weight loss, restlessness, depressed mood, and then at least one of the following physical symptoms: abdominal pain, shakiness, tremors, sweating, fever, chills, or headache. So they can get this flu-like syndrome that we also see in caffeine withdrawal syndrome. C, it's got to cause significant distress or impairment, and that can be either your place of employment, your social settings, certainly if the patient has been arrested or charged with any kind of offense for having the marijuana and yet they still continue to use it. And then also if you're talking about college or high school age kids using it, getting caught, that's distress or impairment as well, regardless of whether it really distresses them. When we talk about impairment here, we're talking about negative consequences. Not just whether or not it bothers the patient. And then finally, D, obviously it can't be attributable to another medical condition, mental condition, or other substance. Caffeine withdrawal syndrome is certainly something you can imagine, probably because doctors have a tendency to sip on the coffee a lot, and now that we've got these energy drinks, Red Bull, Blue Ox, Monster, that have significant amounts of caffeine in it. We also have those new energy shots, the 5-hour energy, which I relied on a lot when I was in medical school. It's much easier now to get large amounts of caffeine, whereas in the past you would have to drink coffee and, you know, talking 5, 6, 7 cups of coffee, not very easy to consume in one day. But now you can take caffeine pills, you can get it in these energy drinks, which are full of sugar and ridiculous amounts of caffeine. So it's much easier to get this caffeine withdrawal syndrome now than in the past. So you have to have prolonged daily use of caffeine. DSM doesn't really give a period of how long prolonged is, but I would say probably months rather than weeks. B, there has to be abrupt cessation or reduction in caffeine use, followed within 24 hours by 3 or more of the following signs or symptoms. And these symptoms include headache, marked fatigue or drowsiness, dysphoric mood, depressed mood or irritability, difficulty concentrating, and then flu-like symptoms, which can include nausea, vomiting, or muscle pain and stiffness. So really think about it. These middle 3 symptoms are the total opposite of what caffeine does to you. So caffeine makes you alert and more energetic. It tends to put people in a good mood, and then it helps you concentrate. So these middle three things, just the opposite, and that's what we expect in withdrawal syndromes. We expect the general rule is with withdrawal syndromes, you're going to have the opposite effect because you've developed a tolerance, and now your neurons are they've adapted to your use of the substance, and so by adapting, they've brought balance back to your body. And now that you've taken away the substance, now the balance is shoved in the other direction. Okay, so again, this also has to cause significant distress or impairment. Typically, these withdrawal symptoms will be enough to cause the distress or impairment. Since caffeine's not illegal, these patients aren't going to be charged with any crimes related to the use of their caffeine. And then it can't be attributable to another medical condition or other substance. And then finally, we have added gambling disorder, and this is now why we call it the substance-related disorders and substance-related and addictive disorders. So I talked about gambling disorder in the impulse control disorders lecture, though the DSM-5 technically classifies gambling disorder now under the substance-related and addictive disorders heading. So let's get some definitions out of the way because these definitions are important and a lot of times they're misused and obscured. So substance use, that's just when you use a drug or you use alcohol. Alcohol, tobacco, those are drugs from now on, okay? So I go out to watch a football game and I have a beer. That's substance use, okay? Sounds bad, but it's not necessarily, okay? That's just substance use. I go out and have a beer. Substance abuse. So substance abuse is when you are engaging in substance use and that substance use poses a risk to you, it poses a risk to your well-being, it poses a risk to those around you, or it results in a maladaptive change in your life. Okay, so I go out and I drink a beer, and then I get behind the wheel of a car and I almost hit a pedestrian. Now my substance use has changed to substance abuse. Or if, let's say, I go out and have 5 beers instead of 1 beer, and now I'm intoxicated. And not only am I intoxicated, but I am I'm getting sick and I'm missing work. That's substance abuse. So it's when you use a substance and it either poses a threat to you or those around you, and it leads to a maladaptive change in your life. That's substance abuse. Substance intoxication is just simply the effects of taking the drug. So I go out and have a beer and I'm more talkative. That's substance intoxication. Substance intoxication can also be I go and shoot up heroin and I die. That's an effect of substance intoxication. So it runs the gamut from totally benign to deadly. Substance tolerance. So this is when you have adapted to the drug, or your body's adapted to the drug, and now you need more of it to get to the same desired effect that you want. So let's say every week, every Monday and Wednesday, I go to the bar to watch the baseball game, and I just have a beer. And now, a few months later, I'm not as talkative just after 1 beer, so I drink 2 beers. That's substance tolerance. I'm tolerant to 1 beer, so now I need 2 because I want to be talkative. I want that effect. I've developed a tolerance. You can also have tolerance having a tolerance doesn't mean you take more. It just means that you don't get the same effect by the same amount that you've been on, okay? So substance withdrawal is when you have symptoms when you're not having the drug. So I have 3 beers every day, and then I stop for a day because I'm going to church or I'm with my family. And now, because of I'm not having beer, I feel symptoms of anxiety, I feel tremulous, I feel sick. That's withdrawal. Withdrawal is the symptoms you get after heavy or prolonged use, and it's the symptoms you get because you're not using it. Substance dependence is a behavioral change in your life. You are dependent on the drug because you want it so much and it's so expensive, so you have to change your life, and you lose control of your life, and you lose control of your ability to decide how much you want to take, and you've had social changes in your life, but you don't care, you want that drug. You are entirely focused on that drug. You are now dependent on that drug. Everything your life revolves around is that drug. And so what I put down here are 3 different aspects of substance dependence. The first being monopolization. That means that all you think about is that drug. All you want to do is get money. All your money goes for is into that drug, or most of it. That's monopolization. Loss of control means, I used to be able to stop at 3 beers. Now I might go out and have 9 because I want to have fun. But I don't care. That's a loss of control. You can't stop yourself at a certain level. Social changes. Well, you can imagine that if you're spending all your time and all your money doing a certain drug and you can't control it, you might lose your friends. You might get in with the wrong crowd. And that might lead to other problems like rape or violence. Social deterioration is another hallmark of substance dependence. So how do we know if a patient is on a substance? Well, 1, the patient might just tell you. 2, the urine tox screen is positive. That's pretty reliable. 3, the patient's family or friends tell you. That's generally happens if they're in the emergency department and not conscious. Or 4, there are signs on the physical. Always remember your ABCs first. So we're going to talk about a lot of symptoms of intoxication. But if the patient comes in and they're not breathing, or if the patient comes in with head trauma, the first step is not to treat the intoxication. The first step is to save the patient's life. So don't forget about your ABCs here. So what do we need to know about the patient? First, we need to know what drug do they use. And clinically, usually they've used more than one at that time. But on the USMLE, they're usually going to just isolate one drug at a time in the patient. So we can usually get a good idea based on the symptoms that the patient's displaying. We also want to know how much, how often, and how long the patient's been using the drug. Why? Because it tells us about the patient's level of dependence. It tells us about the patient's lifestyle. It gives us a good deal about the patient's history. So that's going to be important information. Basic information from the history and physical are always going to be important. So what is substance dependence? We already kind of talked about it. Substance dependence in and of itself is a disorder. So it's characterized by severe negative interference in the patient's life with an inability or unwillingness to quit. So these patients know that they're dependent on the drug, even if they're denying it, they know it. And so it's leading to all these hallmarks of substance dependence that we talked about earlier. And usually there's going to be prominent social deterioration. The patient may have been held down a job, had a family, and now they're homeless and living on the streets. That's social deterioration. And that's very, very common to see that with patients with substance dependence. Family history is a risk. Children of alcoholics are at higher risk to become alcoholics. Comorbid psychiatric illnesses are a risk. You can imagine if you're depressed, well, what's going to be the thing a lot of people turn to? They turn to the bottle. That's not uncommon. Social interactions, that's a big deal too. If your friends do weed, you're probably going to do weed. If your friends do heroin, you might be at higher risk to do heroin because they might persuade you into doing it. So also expect the patient to deny dependence. Cage questionnaire is a good one that USMLE likes to throw at you. So basically these 4 questions: have you ever felt you should cut down on your drinking? Do you feel angry when people confront you? Do you ever feel guilty about it? Have you ever used alcohol as an eye-opener? This is specific to alcohol. You can't substitute other drugs for this. This is specific for alcohol, but if the patient answers 2 or more of these as yes, you can classify that patient as dependent or an alcoholic. So how do we treat patients with substance dependence? We, of course, have primary prevention. So that primary prevention is going to be preventing the dependence from happening in the first place, and that's like the DARE programs in schools and some public service advertisements that the Ag Council puts on. Secondary prevention, these are specific to certain drugs, some of these are for any of them. So rehab programs and detoxification. Inpatient detoxification is good to get the patient off their withdrawal symptoms or to get them out of their intoxication. Rehab programs are good as an outpatient therapy because it allows the patient to connect with other patients who are in the same boat, giving them a support group, and a lot of these also provide counseling for the patients to help them deal with any secondary psychologic addiction that they have. So even though you treat withdrawal symptoms, you might not treat the psychologic addiction. And that's what these rehab programs are good for. One of the most prominent of rehab programs specific to a drug are Alcoholics Anonymous. So it's a 12-step program. It works really well. This is going to be your outpatient treatment of choice for any alcoholic. Naltrexone is an opioid blocker. This is good for patients who... now, let me explain this clearly. You don't use this you don't use this drug in a patient with heroin withdrawal or opioid withdrawal. You use this drug in a patient who is addicted but not experiencing symptoms of withdrawal and hasn't taken the drug but is at risk because of a psychological dependence. Okay, so this is an opioid blocker, and what this does is the patient takes the naltrexone every day, and maybe they go and shoot up heroin one day. What this does is it blocks the effects of heroin. It blocks some of the pleasurable effects, so the patient's like, oh, well, this isn't that great, so they're less likely to do it again. Naltrexone, good drug for patients who are not in heroin withdrawal, but are at risk to relapse. Disulfiram is an interesting drug that is sometimes given to patients who are alcoholics. Please keep in mind, you cannot give this or any drug to a patient without their prior consent and knowledge. So you must explain this drug to the patient and its effects before you administer it to a patient. That's just an ethics thing. What this drug does is it blocks aldehyde dehydrogenase. That is an enzyme that breaks down alcohol. And so because that enzyme is blocked, it leads to some severe toxic effects, unpleasant toxic effects of alcohol, which is severe vomiting and nausea if alcohol is consumed. So it's really just a negative reinforcement. Methadone is good for patients in opioid withdrawal. So remember, naltrexone, not for patients with opioid withdrawal. Methadone, you can use this for patients in opioid withdrawal. And what this is an outpatient therapy, and the patient goes into the methadone treatment center and they get their methadone and they take it, and it gives them kind of the same effects as the heroin gave them, but gradually we move them down, very slowly, down their dosage of methadone. And the good news is that it reduces the withdrawal symptoms. The patient hardly realizes it, and before you know it, you're giving them sugar pills, and the patient is no longer having withdrawal effects. So the specific drugs, I divide these into 8 categories. First, we have our legal drugs. We have stimulants, sedatives, hallucinogens, date rape drugs, opiates, marijuana, and then there were 2 of them that didn't fit any of these categories, so I just kind of lumped them into another category. So alcohol, most commonly used and abused drug in the U.S. How many of us have not drank alcohol? Not a lot of us who live in the U.S. So it is measured with BAC. That is, when we take blood out of a patient in a trauma situation or in an emergency room, we always measure the alcohol concentration. It gives us a good idea of if the patient is intoxicated with alcohol. Alcohol, contrary to popular belief, is a depressant. Why is it contrary to popular belief? Well, because most of us, we don't drink that much alcohol. We might have a beer or a glass of wine. And what does that do? It produces euphoria and talkativity. When we think of euphoria and talkativity, we don't think of depressant. But it is a depressant because ultimately it can cause respiratory depression and death if you take too much of it. So we know that whole spectrum of alcohol intoxication. A lot of us have been alcoholically intoxicated to the point where we are clumsy or maybe even sedated, or we've had a hangover, nausea, vomiting, etc. Those are effects of alcohol intoxication at higher levels. Most of us have not been at the level where we've been in coma or death. That's a much, much, much higher level of alcohol intoxication. So we have a patient who comes into the hospital and they have a BAC of 0.19 and they're intoxicated. What do we do? Well, in any patient, we have to first look at the ABCs. Usually a patient who's, at the legal limit or even twice the legal limit, they're not going to be in need of intubation. They're not going to be respiratory depressed. But make sure if a patient comes in and they're respiratory depressed, you always intubate them. So keep in mind your ABCs. Anytime you give fluids to a patient who has alcohol on their breath or who has a BAC level, you are always, always, always going to give that patient thiamine if you give them any fluids. And this is very important. Why is it important? Because you don't know what patient is intoxicated because they had a random night drinking and they hardly ever do it, but they happen to drink too much and now they're getting IV fluids. Or if it's a patient who's a chronic alcoholic who has liver failure and they've been drinking every night for the last 5 years and they are severely dependent on alcohol. These are two different patients, but the patient who is a chronic alcoholic, if you give them IV fluids and say they're not conscious, so you can't get this history, if you give them IV fluids, you can precipitate Wernicke-Korsakoff syndrome by giving fluids without thiamine. And so we always, anytime we suspect alcohol in a patient and we're going to give them IV fluids, which usually happens in trauma situations, it usually happens in intoxication in the ED because the patient's probably been vomiting and they're nauseous or might vomit. And also because alcohol is a diuretic. If you give fluids to a patient that you suspect has been using alcohol, even if it's the slightest suspicion, you are going to add thiamine, okay? Big point on the USMLE. They will test you on this because you can cause a big problem in a patient if you don't. Withdrawal symptoms for alcohol include tremor, anxiety, and seizure hallucinations. If the patient has seizure and hallucinations and they're withdrawing from alcohol, this is something called delirium tremens. So, when an alcoholic patient is admitted to the hospital, after we're done giving them their fluids with thiamine, we want to prevent DTs. Why? Because, apart from the fact that DTs are bad, patients who are alcoholics, even though they're alcoholics and we don't want them to have DTs, they're not allowed to drink alcohol in the hospital. So we are going to give them chlordiazepoxide, not on an as-needed basis, but on a scheduled basis. And this is a benzodiazepine, and it's going to prevent them from developing delirium tremens. So chlordiazepoxide for any alcoholic patient who is admitted to the hospital. This isn't the patient who comes in and they had a drink and now you're going to admit them for one reason or another and they're not an alcoholic. This is for your chronic alcoholic patient that is being admitted to the hospital. Give them chlordiazepoxide, scheduled, a benzodiazepine. It prevents them from getting DTs. Management of DTs, if they develop it. These patients are hospitalized. They need supportive care and benzodiazepines. And you're going to give them one of the shorter acting benzodiazepines like diazepam or lorazepam, the benzodiazepines that are given for seizures. Okay, so let's shift to nicotine and tobacco. These patients will not be in the ED, and if they are, you're not going to be treating their nicotine and tobacco usage. These are the patients that come into the clinic and they say, "Doc, I want to stop smoking." Or they're the patients that have risk factors for coronary artery disease and they smoke, and you tell them, "You must quit smoking." So the long-term effects of smoking or chewing tobacco are respectively lung cancer and leukoplakia. Of course, we also have COPD. That's also very important with smoking. Management is going to be quitting, and then what we do uniquely is we treat the withdrawal symptoms. We expect they're going to have withdrawal symptoms. Most people who've smoked have smoked years and years and years and years, decades. So we want to treat the withdrawal effects, which are anxiety, irritability, increased appetite, and drowsiness. So we do this with nicotine replacement therapy, which is over-the-counter, gums, patches, your Nicorette, all that stuff. We can also use prescription drugs. The two that are out there that are used most commonly are varenicline, which is Chantix. You see it on all the commercials. I don't like this drug. A lot of patients I've given this drug to have had problems with it, and that's probably why I have a bias against it. You don't see it come up on the USMLE hardly at all. I've never seen it come up on the USMLE. There are side effects for varenicline. It's a nicotine antagonist, and the side effects can be psychosis, suicidality, even homicidality. So I don't like this drug, but it is out there. Some people like it. They swear by it. Bupropion is the drug that's going to come up on the USMLE for medical management of nicotine and tobacco use. So bupropion is simply an antidepressant, and it works very well for patients with refractory nicotine addiction. Inhalants. This is a big deal among teens. Why is it a big deal among teens? Well, look at that picture. Those things are you can buy them if you're 5. You don't need an ID to buy these things. And yet, by sniffing this stuff, paint solvents, glues, thinners, household cleaning products, you can get symptoms of slurred speech, delusions, decreased motor coordination, wheezing, belligerence, psychosis. Kids are stupid. They like to do this stuff because they're curious. You're going to see this among 15, 16, 17-year-olds. You're not going to see this among a 40-year-old. So if you get a question of a patient who's 14 and they're intoxicated, inhalants should be at the front of your mind. Also think about alcohol and other stuff because they can do that too. But inhalants are unique among the pediatric populace. A lot of times you're going to smell an odor on the patient. That's usually not common with alcohol and the other things, especially cocaine. You're going to smell an odor on the patient. Yeah, with alcohol you might smell alcohol, but that's got a very particular odor. With inhalants, you might smell WD-40 or paint thinner. That's not something you usually smell on a patient unless they've been doing something. So you'll smell an inhalant odor on the patient. The management here is just supportive. There's no withdrawal symptoms from this. It's just supportive management. Usually these kids are going to need psychotherapy in the long term, but antipsychotics can be used if these patients do get agitated because inhalants can cause belligerence and psychosis. So antipsychotics, as usual in the ER, you can use antipsychotics as necessary. Cocaine and amphetamine. So these are some harder drugs here. The common sort of pathway between the two of these is that they block the reuptake of dopamine and serotonin and norepinephrine. Don't get at me about the pathway. You're not going to need to know this for step 2 or 3. If you want to look it up, fine, but I'm not getting into that here. Symptoms of cocaine and amphetamine intoxication. So the short term is euphoria, increased motor activity, restlessness, reduced appetite, increased body temperature. Why did I italicize increased body temperature? Because that can be deadly. So in any patient who comes in and the urine tox screen shows cocaine or amphetamine intoxication, or you suspect cocaine and amphetamine intoxication, make sure, in part of that supportive care that I underlined down there, make sure that you're monitoring their body temperature because they can develop hyperthermia. Mydriasis, I bold-faced that because that is something that the USMLE will almost always tell you. They've got dilated pupils. They're itching and paranoid, they've got increased motor activity, and they're restless, and they've got dilated pupils on physical exam. Mydriasis is very, very, very associated with cocaine and amphetamines, especially in the USMLE. Okay? So keep that in mind. Management for intoxication of cocaine and amphetamines. Supportive care. Yeah, you're probably noticing a pattern here. So that supportive care is going to include benzodiazepines if the patient is restless. You can give them one of the shorter to medium acting benzodiazepines. Good one is Versed, Xanax can be used too, respectively. Those are midazolam and alprazolam. But really any benzodiazepine will be fine. Antipsychotics can be used as needed for the paranoid delusions and for any kind of psychotic behavior they develop on the wards. Beta blockers are great. You're going to usually use propranolol or Inderal here for the tachycardia or palpitations. Vitamin C is used. It's somewhat controversial, but I think it's pretty standard for cocaine and amphetamines. What vitamin C does is it acidizes the urine, and that speeds the excretion of cocaine and amphetamines. So that's good for management of intoxication. Withdrawal syndromes. So the withdrawal syndromes for cocaine and amphetamines. Right now I'm just going to go let my dog out. Actually, no, he's fine. somebody just got home. So anyway, so withdrawal syndrome for cocaine and amphetamines. Just think of the opposite of what the intoxication symptoms are. So withdrawal from cocaine are going to be depressed mood, as opposed to the euphoria. It's going to be anxiety. It's going to be tremor. It's going to be increased appetite as opposed to the decreased appetite. You can treat this long term with SSRIs or any kind of antidepressants, but we use SSRIs. That's going to be your treatment of choice on the USMLE. Benzos and barbiturates. So these are your sedative hypnotics, and they are prescription medications. You're going to see benzodiazepines a lot more. Barbiturates are not common to be prescribed these days. So symptoms of acute intoxication are going to include behavioral disinhibition, somnolence, sedation, and respiratory depression. You see these in suicide attempts. Why do you see these in suicide attempts? Well, who do we prescribe benzodiazepines to? We prescribe these to patients who are having anxiety disorders. Are people with anxiety disorders more likely to commit suicide? Yes. And so where are they going to go? They're going to go to their benzos, they're going to go to their Ativan, they're going to go to their Valium, they're going to go to their Versed, and they're going to overdose. So you see this a lot in suicide attempts. The management for any kind of benzodiazepine or barbiturate overdose is going to be supportive. You're going to want to monitor their pulse ox because there is a possibility of respiratory depression in these patients. If respiratory depression ensues, you're going to intubate them, and flumazenil is the treatment of choice to block the benzodiazepine. It's the antidote. I will say that flumazenil is not used commonly in the ED, but you will see it come up on the USMLE as sort of a trivia. What do we use in a patient with, in this patient with benzodiazepine overdose? Flumazenil would be the treatment of choice. 1 second. Okay, so the withdrawal symptoms for benzodiazepine include anxiety, insomnia, hyperactivity, decreased appetite, and seizures. So why anxiety, insomnia, and hyperactivity? Well, think about what benzodiazepines do. They calm you down. So the opposite, the withdrawal, is going to be increased motor activity. Seizures, well, think about what benzodiazepines are used for. They're used to treat seizures, so the withdrawal will include seizures. Decreased appetite is also another withdrawal symptom of benzodiazepines. You can treat benzodiazepine withdrawal with longer-acting benzodiazepines. So you may be curious as to why, if you're getting a question on how to treat benzodiazepine withdrawal, why are you getting a list of benzodiazepines? Well, because what do people usually take when they abuse benzodiazepines? They take the short-acting benzodiazepines, the ones that give them a high, the Ativan, the Xanax, the Versed, the Valium. These are the ones that cause addiction. And so these are the ones that people are going to withdraw from. And so what we like to do is when we treat patients with benzodiazepine withdrawal, we like to use the longer-acting benzodiazepines because while they don't give the patient that high and perpetuate the addiction, they do reduce the withdrawal symptoms by acting over a longer period of time. Best one to use here is clonazepam. You could also use chlordiazepoxide, but that's more commonly prescribed in alcoholics going through alcohol withdrawal. Hallucinogens. So I put the 4 of them here that we're going to refer to. Lysergic acid diethylamide is LSD. Mescaline is less commonly used. Psilocybin is the active ingredient in the hallucinogenic mushrooms. And then PCP, which is unique in that it's set apart by symptoms such as agitation, aggression, something called hyperacusis, which is sensitivity to sound, and then more importantly, seizures and coma. So these drugs work in various mechanisms. The symptoms of intoxication are going to include hallucinations, psychotic thought process, which, as we remember from schizophrenia, is ideas of reference, decreased judgment, clumsiness, and mydriasis. So mydriasis is, like we just talked about, dilated pupils. PCP is going to include the above plus agitation and aggression and possibly seizures. So PCP, okay, so if you're on mushrooms, if you're on mescaline, if you're on LSD, you're going to be just sort of hallucinating and just kind of blissfully there. Patients who are on PCP are mean. They're agitated, they're aggressive, And so those patients are going to be pretty clearly distinct from, they both hallucinate, but patients with PCP are sort of your mean hallucinators. So that's how it kind of sets them apart. The management is the same. It's supportive. You talk these patients down, you reassure them, they tell them everything's okay, especially if the patient is frightened. Antipsychotics can be used if they're needed. Usually they're not. We usually just support these patients and then they come off their high. If we confirm PCP or it's highly suspected because they're agitated and they're aggressive, use benzodiazepines for seizure prophylaxis because these patients are at increased risk for seizures, especially if they're agitated. And of course, antipsychotics are always going to be indicated if the patient is posing a risk to themselves or others. There's no addiction profile for hallucinogens, and therefore there are no withdrawal symptoms. Date rape drugs. So you're not going to see these patients in the emergency department or the clinic. Why? Because patients who are intoxicated from date rape drugs are surprised being date raped. So that's an unfortunate reality. So what I wanted to put in here while we talk about date rape drugs is, what do you do when a patient comes in after they've been date raped and, for instance, they know it? So patients who have potentially been raped always need to get a cervical exam for forensic and STDs. And here, yes, we are assuming the patient is a woman. That's the vast majority of date rape patients. So any rape patient, really, this refers to. Cervical exam for forensic and STDs. So we want to check for forensics because if this goes to trial, we want to know who the potential perpetrator was. And STDs, because if any STD was passed on to the patient, we want to know. Clothes must be stored within 24 hours of the event happening. And then we're going to want to get this patient psychological counseling and community counseling service, like a social worker. The clinician, you on the USMLE, or in real life, usually there's a hospital coordinator for these sorts of things, are going to notify law enforcement. The most commonly used drugs for date rape are flunitrazepam or Rohypnol, which is a benzodiazepine, and gamma hydroxybutyrate, which is a depressant, and sort of causes the same effects as alcohol. Opiates. So we're going to talk about heroin as the premier opiate. What they do are bind opioid receptors, and they are administered intravenously. So on physical exam, you're going to see needle marks, usually forming a track. Why forming a track? Well, because these patients find a vein, and they say, okay, here's my vein, and then they follow up that same vein. So you're going to see a track of needle marks. Symptoms of intoxication are going to include blurred vision, drowsiness, apathy, slurred speech, dysphoria, and then coma and death. And unfortunately, a lot of patients who have a heroin intoxication will present with coma and death. Why? Because different formulations of heroin that you get on the streets, of course they're not regulated, so you don't know how much is in each one. Some of them are going to be really, if you're the drug user, crappy, because they don't have a lot of heroin in it. So you might think, okay, well, 10 milliliters, I don't know how much they use, does it for me. So they use 10 milliliters. Then they go somewhere else and they get the really, really, really good stuff. And they inject themselves with 10 milliliters, and it had a higher concentration of heroin, and they overdose, they die. Sad reality. I bold-faced here meiosis. This is constricted pupils. Definitely word associate meiosis with heroin or meiosis with opiates. Constricted pupils equals opiates. So keep that in mind. If you have constricted pupils, it doesn't always mean you're on heroin, but meiosis is going to be part of the constellation of symptoms that you get with heroin or opiate intoxication. The management here is with IV naloxone, and what naloxone is it blocks the opioid receptor, so it prevents heroin from working. So you administer IV naloxone to any patient that you've confirmed is intoxicated with opiates or heroin, and then you're going to monitor the pulse oxidation. The withdrawal symptoms for opiate intoxication include fever and chills, runny eyes, runny nose, yawn reflex, body pains, especially in the abdomen. So you're going to manage this when the patient is in the hospital. You're going to give them clonidine, and then when you discharge the patient, you're going to refer them to a methadone treatment center. We kind of talked about methadone earlier. Marijuana. So this is really, I'm going to say, not a dangerous drug. It's very frequently used. It's illegal in most U.S. states. It is legal, however, in Colorado and Washington, but it's illegal at the federal level. So marijuana intoxication is usually an incidental finding on a urine tox screen, usually when you're screening the patient for other drugs. Marijuana is very commonly used among patients who use other drugs, but the reverse is not true. It doesn't mean that patients who use marijuana use or are likely to use some of the harder drugs. And I think a lot of the myth about the gateway drug has been sort of dispelled. So sometimes you will see a patient on the USMLE because they want you to know what marijuana intoxication looks like. It doesn't mean that you ever really see marijuana intoxication in the ED, but the symptoms of marijuana intoxication are worth talking about. That includes red eyes, increased appetite, aloofness, disturbances in time perception, occasional disturbances in sensory perception. Of course, that's rare. No management is necessary for these patients. There's really nothing to do about it. The only time you'll ever see these patients in the ED is if their parents bring them in. Long-term effects of use of marijuana are controversial. Certainly the long-term effects of alcohol and tobacco, which are legal drugs, are definitely more pronounced than marijuana and are much more dangerous. So, something to keep in mind. This is non-addictive and there are no withdrawal symptoms. Really the most dangerous thing about marijuana is purchasing it and carrying it. Anabolic steroids you're going to see in teenage and young adult males. Why? Because these guys like to build their muscles and they go to the gym and they find that it doesn't work or they're not doing it the right way, and so they lapse over to using steroids. Some of these patients can become intoxicated with these steroids and have psychiatric symptoms, and those include aggression, well, that's really the only psychiatric symptom because they are steroids and because they're not a psychiatric drug per se. You're going to see symptoms on the physical exam, including muscular hypertrophy, breast enlargement, acne, hirsutism, and testicular shrinkage, which is rare. Management for these patients is going to be supportive. They're going to need counseling and psychotherapy. Antipsychotics can be necessary at times if they are showing aggression. Long-term use can lead to cardiovascular problems and hypercholesterolemia. So this really is not something that you want to get into the habit of doing. It, however, is not addictive because it doesn't work on any kind of nerves. It works inside the cells. So this is a non-addictive, it's a non-psychiatric drug, there's no withdrawal. So the designer drugs are ecstasy and ketamine. Those are the ones that I included on here. They're the most frequently used. The symptoms of intoxications are really subjective. The patients will usually describe symptoms consistent with depersonalization, which is where you feel like you're outside of your body. Symptoms of psychosis, which obviously include delusions and hallucinations. Altered perception of space and time. These really aren't necessarily dangerous drugs, but they can lead the patient, because of anything that causes hallucination and anxiety, can lead the patient to do things that are dangerous. So taking the ecstasy or the ketamine in and of itself is generally not dangerous, but if you're having hallucinations that there's a really attractive woman stuck in the middle of the street when in reality it's cars going 50 miles an hour and you run out there trying to save her and then you get hit by a car, well, that's a bad thing. So anything that causes hallucinations can be dangerous. So it's not necessarily the drug that's the problem, but it's the effects of the drug and what it causes you to do. So The management, therefore, is going to be supportive. We're going to get them down off their high. After that, we discharge them with the usual instructions: don't do this. It has a very low addiction profile, and therefore there's no significant withdrawal. And this is the effect of drunk driving. So I think out of all the drugs we talked about, alcohol is the most significant, even though it's legal. Why is it the most significant? Because it's so commonly used and therefore commonly abused, and therefore things like this happen at a very large scale. And so you can see blood on the road, you can see clothes, you can see parts of the car. This is really unfortunate. So I know it's a somber note to end on, but when you think about drugs, you really have to think about the most commonly used, and because they're the ones you can see the most. So we'll talk in the next section.